PRRT is a very exciting new addition to the treatment for NETs. Although it can be very successful, it is not successful for everyone. There are a number of people who do not respond to PRRT or who develop resistance to PRRT. And so it is essential that we try to figure out how we can make PRRT even better than it is.
It's demonstrated that patients who have lesions with a high expression of somatostatin receptors, so intense positivity at the ganglion, DOTA-TATE PET-CT, have a much greater chance to respond to PRRT. And that is why it is because to a high concentration of a radiotracer in the tumor corresponds a high irradiation, a high delivery of radiation dose to the tumor cells, and hence the higher chance of achieving a response.
Opening the therapy up to patients who have much lower levels of somatostatin receptor expression, if we can further sensitize the cells by using a PARP inhibitor, we expect that this will make it a more effective therapy, particularly in those patients. The benefit, I think, will be twofold of this approach. One is opening it up to patients who would otherwise be unlikely to respond, those with lower expression of somatostatin receptors, which is around 15 to 20% of patients. Also, I think it's going to increase the effectiveness in a group of patients in whom, despite appearing to be suitable for the therapy, and we give multiple cycles of treatment, the tumours don't seem to respond.
But there's still a lot we don't know about PRRT. We don't know exactly why some patients respond and others do not. We don't know the most effective administration, whether it's intra-arterial or intravenous.
We would like to discover if it's possible, or improving the therapy, if we combine a new radionuclide which is emitting particles for killing tumor cells with a long and a short range tissue range. And that's something which nobody has done so far. With terbium-161 we are the first group which is doing that systematically in the whole world. And now with the new isotope, I think with even a shorter range in tissue, killing eventually single cancer cell, we think that we can actually improve the survival and particularly also to reduce the relapse of patients suffering from neuroendocrine tumors.
We're using yttrium-90 or Y90 instead of lutetium-177, so we're using Y90 DOTA-TOC, and Y90 has a couple of characteristics which are different than lutetium that will make it more effective in treating tumor, but also carry more toxicity risks associated with it. With the technique that we're using, we actually put a catheter into the artery that feeds the liver and administer the Y90 DOTA-TOC directly into the liver. And the rationale of that is that when you put it directly into the liver and you have a bunch of metastases in your liver, those metastases will absorb the dose on the first pass. The first time the dose goes through the liver at a higher fraction or higher concentration than if it were given through the vein in the arm. So we're getting higher uptake in the liver, and then we're using this type of Y90 dose that will have more efficacy, and hopefully we minimize the toxicity by giving it through the artery so that less of it gets systemically to the rest of your body.
What I really want to see is access and availability, and working on some of these isotopes and some of these delivery methods that will allow us to have therapies in more centers, not only in the US, but around the world. One of the advantages of donating and working through the Neuroendocrine Tumor Research Foundation is that with our reach and with the ability to fund projects around the world, we're able to see the best projects that are going on right now, and the quality of the projects is getting so much better.
We think it's important to go into research in these other areas so that we can continually improve PRRT and make it an option for many more patients.